We'd like to welcome you to the Healthcare Revolution podcast, where we empower you to take control of your health, restore your trust in the medical system, and achieve lasting wellness. I am your host, Brad Powell, Doctor of Physical Therapy and owner of an award-winning foundation physical therapy here in the Salt Lake Valley. Each episode, we dive into all things rehab prevention, overall health, bringing you expert insights from leaders across the healthcare fields. Please note, while we aim to provide with the best knowledge and advice, the opinions shared represent those of experts in the field and are not to be replaced with professional medical advice. So let's revolutionize healthcare and wellness together. Welcome to the podcast this morning. I am so excited to have with us Ty Berrett, who is an absolute legend in my profession. And this year he won the award to become pretty much the strongest advocate in our profession for Utah. And I don't want to underemphasize that, because the work that he's done this past year has been monumental. He's stood behind the scenes and not had a lot of recognition. He doesn't like to be in the spotlight, so we're putting him in the spotlight today. I'm going to give a brief introduction, but today we are talking about the value of a physical therapist and why. We've talked about this primary care bill in the past, but we're talking about why this matters for the consumer, for the patients that are coming to us, and how it improves the healthcare system. So, long story short, Ty, first of all, welcome to the podcast.
Thank you very much. Glad to be here.
Great to have you here. I'm just going to go over a brief bio from Ty. He's the executive director of the Western Rehab network and one of Utah's most influential advocates for physical therapy. He's not a physical therapist, but yet one of the strongest advocates. He's spent decades elevating the physical therapy payment models, empowering our clinicians to understand their value, and in uniting the healthcare leaders around policy change. He's recently been honored with the Choose PT Champion by the APTA Utah for his advocacy, collaboration, and his instrumental role in passing the primary care bill, which has been a milestone for expanding patient access and elevates our role as physical therapists. So thank you for your advocacy and what you've done this past year. It's been monumental.
It's been a lot of fun. I've enjoyed it. Being involved with APTA Utah much more on that level, and in conjunction with other practices outside of my past role, it's been a really good time.
Yeah, so I remember the first time we made contact. It was with this $2 bill. I almost brought it today. I totally forgot when I was walking out. I now have it on my desk in my home, and it's this $2 bill. And every time I look at it, I think of you, for one, and for two, I got a piece of mail. And as, a business owner, I was early in practice. I think I'd just been opened, maybe 6 months, I want to say. And I got this letter. But it was interesting. There was a $2 bill in it, so it was different. And I started to read it, and it said, Ty Berrett, do you know your value in physical therapy? Right? And I started to read it. I'm like, what is this about? And before I give more on that, what was your intention behind this $2 bill? What was the impact that you hoped that it was going to create?
How often do you see a $2 bill?
I mean, it's rare nowadays.
Right.
It has to be really intentional, because you actually have to ask the bank for a $2 bill.
Exactly. A $2 bill gets the attention of the person. Of course, green money gets the attention of a person inside of an envelope. How often do you get cash in an envelope? Okay, so those are two factors. The really behind the $2 bill is the fact that it's unique. It's not something you get on a recurring basis. In my day, when I was a child, we got them for birthday gifts from grandparents. So that was the factor. Is it creates an excitement, it creates a thought, and in your mind, it's now been 4 years or so. It's always been in the back of your mind. When I talk to people that received the $2 bill from me, they still remember it. So it's not like it's something that was just in passing. The intent of the whole purpose was bring awareness to physical therapists about their value. The value of what they do in the communities we serve. That's the whole goal.
Yeah, I love it. And we're going to dive more into that. Today, our conversation's mainly about why this matters to physical therapists financially, why it matters to you as the patient and society, and why PTs are among the best diagnosticians in healthcare. We're going to go into a few studies and some research here, and then how this reshapes the future of what we call musculoskeletal care, which is like you get an ankle sprain or you hurt your back. how does this shape our future? So those are the big things that we're talking about today. But I want to go back to this $2 bill because it started my whole journey. You know, all of my extra work, I am grateful to you, but also it's your fault why I have extra work.
I'll take the blame for it.
It's really ignited this thing in my life that I never thought existed. You know, it's been a portion of why this podcast was started in the first place. So thank you, for one, for sharing that, you know, your income with me and giving me that $2 bill. But I remember, man, and that's why I keep that $2 bill on my desk today, because in the letter it talked about, do you know your costs and your break-even point as a physical therapist? What are you worth as a doctoral level graduate physical therapist? Like, what is your dollar? How much should you be making now that you have this degree, right? That was kind of the overall message. And at that point, we were taking contracts that were paying us an extremely low rate, almost $20 lower than our costs. So just for people that are listening to this, it's pretty much saying, you know, when I owned a painting company, I'm going to go paint Ty's house. That's pretty much saying it costs me $2,000 to paint his house, but I'm only going to charge him $1,800, right? I'm going to lose, you know, $2,000 or $200, $1,800, $2,000. Yeah, I can do the math there. I'm going to lose money on this job, right? That's essentially what I was doing as a private practice owner. So the intention, again, behind this letter was to say, do you want to take those contracts with these insurance companies? Because certain insurance companies shortchange healthcare workers, and it's really hard for us to function and make a livelihood if we're losing money on every patient. So I won't go into specifics of what insurance companies shortchange us, because that's not the topic today. But just know that certain insurance companies pay us higher amounts, certain insurance companies pay us lower amounts. And our intention was to get rid of the lower paying contracts, not to serve patients less, but to allow us to serve the patients that we want to better, and essentially create better care for the patients that we were seeing. Because if I have to see 4 patients per hour to make ends meet, but then I could see 2 patients per hour, my quality of care is going to go up because I'm getting paid better with those 2 patients and trying to crank through 4 patients. Tell me your thoughts on all that, Ty.
Well, it's exactly right. I mean, you hit the nail right on the head. The idea behind the letter was to bring awareness. You know, a lot of therapists got into the business so many years ago, or they got into the business and signed a contract because it made them or gave them the ability to be on panel with a payer so they could accept patients from that payer. A lot of times they don't take into consideration the cost versus the revenue, the income stream. And so the idea behind it really is anybody or everybody paying attention to their contracts? You know, they see 3 or 4 patients a day of this particular payer, and if they're giving away 10 or 20% of their exact overhead to provide that care, what's it doing to their bottom line? What's the doing longevity to the ability to keep a brick and mortar building open and establish the business? At the same time, you know, you look at physical therapists on the sidelines of sporting events and all these kinds of things. The common public isn't aware of that necessarily. So they talk about the doctors that are on the sidelines. Okay, well, the doctors, you know, the MDs, you know, those folks, yeah, they're on the sidelines to take care of them. But at the same time, when you start to deal with musculoskeletal injuries, it's the therapists that are on the sidelines. It's the triage that's being done by a therapist in an athletic event, in, you know, a setting of a hospital, in the setting of a clinic, that really creates the dynamic relationship of the patient and the care. You know, historically, when you go to a physician's office for care, how often do you talk to the doctor for more than 5 minutes? You know, it's come in, they look at you, they talk to you. It's a few minutes. Okay, let's go run some labs, get some images. They look at the images, they look at the lab results. Okay, this is what we're going to do. And then they're out the door and they go see the next patient.
Yep.
Physical therapists, you know, in an eval is 30, 40, 60 minutes. Okay. who's their relationship with, who's the understanding with, who's giving the patient the best insight as to what's going on.
And ultimately creating long-term change, right? And getting to know them and their goals and what they truly want to accomplish. And this is not to diminish the role of a surgeon or a medical doctor, right? They have a certain role in healthcare, and physical therapists do as well. But the value at which we can create for musculoskeletal care is significantly different in the PT profession than in an MD office or a surgeon's office. So again, it's not to diminish what they're doing. It's everyone has their role.
Exactly.
So let's just go back to history real quick for you personally. What motivated you to start in this PT advocacy realm? Because I've never in my career, I mean, I'm only 6 years in, I'm young, but I've never in my career seen someone that's more passionate about our profession than you. And you're not even a PT. So tell me where it all started.
So I have a lot of family members that are physical therapists.
Okay.
So there's 6 of them.
6? You don't mess around. You guys just breed PTs.
Yeah,
okay.
Exactly. So at one point in time, I was on the path thinking I would go, do the same thing, be a physical therapist. Got into anatomy, physiology, and went,
not for me.
Not for me. Got to move on, find something else. So I actually was an aide in a physical therapy clinic for a couple of years in undergrad, thinking I was going to go to PT school. When I made the change to go more along the business model, I switched and stayed in healthcare, but started doing occupational health services, ER-based OCMED. And
tell me what that is.
Occupational health services are the services related to employers for injuries, risk management services like drug screens, physicals, respirator fits, those kinds of services that are required by OSHA and or state regulations, DOT laws, those kinds of things. So there's a need, continues to this day from when I did this back in the early 90s. We were building it out of emergency rooms of hospitals. As we all know, emergency rooms have very high expensive costs and fees to work in those. Employers need to get services done. And back in the day, urgent cares weren't on every street corner like they are today. And so we were building them out of emergency rooms. So I did that for a few years. A few years later, one of the groups and a family member called me back and said, "Hey, we need you to come back into the fold. We want to have you start looking and developing our operations, our marketing, expansion of the business into other clinics and other markets." So that's where I made the switch. So I went back to physical therapy 30 years ago after a brief stint in the occupational health world. But it kept me somewhat still related to physical therapy because I was in healthcare. And even though people get injured at work, workers' compensation injuries, they still go to physical therapy during that whole kind of experience of the time I spent doing that.
What drives you, Ty? I've never seen someone work harder and give more heart and your own time. Like I see you make cookies from your own house and deliver them to people. Like you're a giver. Like what motivates you so much to help this profession?
I guess it's the profession I chose. So you got to like what you do when you wake up and go do it, right? So I must like what I do because I've stayed doing it for over 30 years since you called out my decades of service. But at the same time, it comes from the core part of my family, my parents. There's an old analogy that my dad used to tell us years ago was never be in debt to someone. Financially, favors, whatever. It doesn't matter what it is. So I never want to be in debt to somebody, and I don't want people to be in debt to me. But at the same time, relationships are the foundation of a lot of things that happen in this world, whether it be in physical therapy or in school or education or anything of those nature. And a lot of times, recognition through the simple things of life, a bag of cookies can change somebody's day. It's crazy, but it can.
Yeah, absolutely. I love that. And I deeply respect that out of you. I mean, I've watched you over the years. I'm an observer at its finest. I'm a people watcher, and I learn mostly from watching. And you've been an incredible leader on that front, so thank you.
Well, thank you.
Tell me how these early experiences really shaped your mindset in teaching PTs their worth.
The experience itself kind of is the give back. Because I've had the opportunity to do this for so many years and talk to payers, talk to physicians, talk to employers, talk to patients, their feedback is what kind of helped drive this in some sense. The idea behind it is that if we don't recognize our value today, what's going to be there in 10 years or 20 years down the road? There are contracts out there that were signed in 1995 that are still in effect today. So you think about that. That's a 30-year-old contract. Now, think about the impact of, cost of living just in the last 5 years. How can we sustain as a profession and as a business? But the other side of the coin is you sit down and think about it. You go back to my comment about time with the patient. How many patients in your short 5-7 year experience have come to you 2 or 3 times in that 5 or 6 years with a post-op surgery need, maybe after a car accident,
Hurt their back, lifting something.
Yeah, pulling the cord on the lawnmower.
We're part of their journey.
Right. And so now you've established this relationship. So is the relationship with healthcare, it should come through, in my mind, physical therapy for musculoskeletal injuries. Obviously, for diabetics, maybe not necessarily. There is a benefit to them. But at the same time, you injure your back pulling the cord on the lawnmower, who are you going to go see? You talked about this in the introduction, the diagnostic, statistics that happen out there. Who's best at diagnosing musculoskeletal injuries? This is my personal opinion, but I believe it to be physical therapists.
Well, there's actually, studies on this. Bart, forgot Bart's last name, with Mountain Land Physical Therapy. He does all the musculoskeletal ultrasounds.
Bart
McDonald. He presented this research at the last conference that showed each healthcare profession and how they are at diagnostic accuracy compared to an MRI. So let's just say the MRI is what we call the gold standard. So say your shoulder is hurt. If I was to quickly just go get an MRI without examining it, the MRI comes back and says you have a rotator cuff partial tear. The diagnostic accuracy of a physical therapist, I believe, was 76%. The primary care physician was like 30-something%. It was significantly lower. The only profession that was higher than a physical therapist, it was only like 6 to 7% higher, and it was the orthopedic surgeons. And we believe the difference there was because they can test it, do their diagnostic tests, and then they get a peek under the hood to say, yep, I was right, because they get to open it up, right? PTs don't have that same luxury. And it's not to diminish that, orthopedic surgeons were trained really well or were not trained really well. That's not the goal there. It's pretty much to show physical therapists are trained extremely well in diagnostic accuracy of your muscles, tendons, joints, ligament conditions. And we're dang good at it. And we don't use a lot of these other tools. We should use x-rays and MRIs and CT scans more, but we are almost 75% accurate just with the tests that we run in the clinic. That's a pretty good dang statistic.
You're exactly right. I've had the luxury of physical therapists in my family since I was born. So the idea behind utilizing them personally is part of the understanding and the drive. If I had an injury, well, I didn't go to the doctor. I called one of them, or I went and saw one of them. When my kids got injured in sports or, playing backyard athletics, I don't take them to the doctor. I take them to the physical therapist and let them tell me what to do.
Yeah, and really the question
let them drive what the model is that I need to have happen. Do I need to go see an orthopedic surgeon, or do I need to go to the urgent care, or, whatever, based on the injury? We joked about this as family members when we were kids. broken arms, broken legs, broken hands, we'd go a day or two before we went to the urgent care or the ER.
100% Ty.
I mean, our parents would say, rub dirt on it, let's move on.
The thing is I'm not advocating for this, but I've broken over 30 bones, so I've got some experience to share here. But most of the time, no fault to urgent cares, emergency rooms, if it's stable. If you think something's broken and it's swollen, just wait a couple days. Go to you go to your primary care doc, go to orthopedic, guy if you feel like it is broken. Urgent care, emergency room is just going to put a ACE wrap on it and a stabilizer, and that is important. I'm not saying to not do that if you're not educated, but a lot of the times I would wait. I mean, one time I broke both my arms and I waited until this was on like a Thursday. I literally drove home. I could barely hold on the steering wheel. I'm not endorsing this, but I didn't go to the doctor till like Tuesday. The reason is because I learned through experience. Most of the time I was sitting in the emergency room for like 8 hours, and it was like 3 a.m. till I went home, and they had to do repeat imaging anyways because there's so much swelling. It's hard to see, and then they put a soft cast on it and then put an ACE wrap on it, and then they say follow up with the orthopedist, right? So I just skipped that whole process because it was so miserable. I'd stabilize it on my own with my own knowledge, right? I'm not saying do this on your own, but then I just wait 5 days and then they'd cast it, right? Because I had to wait anyways. It was just a gruesome process. But is what I'm trying to say is knowing who to go to is really helpful. Like, who do you go to when you sprain your ankle? Who do you go to when you hurt your back or hurt your shoulder? It should be your physical therapist. There's no one better to treat your musculoskeletal condition. I was working in the emergency room as a physical therapist. I would triage the low back pain. People would come in with debilitating low back pain. And the physicians were so respectful. They're like, you guys, this is your thing. You get in there. And we would treat it in the actual space. And we would solve so many issues just immediately with people that could barely walk. And we're like, all right, I want to see you in the office in 2 days, right? And we'd triage that in the emergency room and then get them in the PT clinic. And that's really how our system should work now, especially knowing the diagnostic accuracy. Because primary care physicians, just because they can't have a high diagnostic accuracy with these tests doesn't mean they don't have extreme value.
Exactly.
They are for illness and for disease and for medication management. They are not there to be the triage and the treatment for musculoskeletal conditions. It's not their role anymore. It used to be, but there's just too many things to manage, and that's why the buck has to pass. And the physical therapists, we need to rise and treat these things really well so we can take that off of their hands because there's too many things to treat. Tell me your thoughts on that.
Well, back in the old days, us old people before cell phones.
Old days.
Yeah, the old days.
Are you like 30-something years old?
We had a Rolodex. And a Rolodex was basically a little kind of a business card holder or a reference of phone numbers and contact information. Nowadays, you have a cell phone with all these contacts in it and all this Rolodex. So you ask anybody, your friends, family, neighbors, whatever, who's the guy or who's the shop that fixes your car? And they can tell you. When your lawnmower breaks, who's the shop you go to or where, who fixes it for you? Who's your hairdresser? Ask any woman who their hairdresser is. They know their phone number, their contact information, everything instantly.
And they probably have an appointment already scheduled.
3 months out, every 2 months or whatever the schedule is. You ask the common public person, whatever, who's your physical therapist? And they look at you like, what? And it shouldn't be that way in my personal opinion, because again, if I injure my ankle, hurt my shoulder, hurt my back, the shortest distance between 2 points is a straight line. Why are we not taking the straight line to the source that's going to be probably the end person or result of treating the injury?
Tell me a pathway that a typical patient takes or could take that would be the most indirect way from point A to point B that you're talking about, from 2 points. What's the passageway that people can take with just something like low back pain?
Well, there's, I guess, probably a lot of paths. If it's 2 a.m., likely they're going to end up in the ER, depending on their pain severity and their pain tolerance and
Tell me the cost of
those
an
kinds of things.
ER visit, roughly.
An ER visit, you're going to start talking somewhere in the neighborhood of $1,500 to $3,000.
So you go to the ER. What's happening from there?
Yeah. Then from that point, they're going to look at you and go, I don't know exactly. They might give you some anti-inflammatories or something of that nature, kick you out the door, and they're going to say, follow up with your primary care physician. Follow up with
How long does
your
it take
orthopod.
on average to get into a primary care physician in Utah?
From what I understand currently, anywhere from 2 to 6 weeks. Now, I've heard people give me horror stories of 12 weeks, but I've also heard some people say 10 days. So,
Okay, so following this journey, we're going to keep this, kicking this can down the road. Emergency room, 1,500, 2,000. Then you're waiting 2 weeks to 12 weeks. You're missing work. You're miserable. All these things. You get that primary care physician, then what? What typically happens?
I'm going to venture a guess that probably 70+% of them are going to get it referred to physical therapy instantly, right then and there. Some primary care physicians will treat it conservatively, through medical or through medication management, maybe do an X-ray or an image, and just say, let's watch it for 3 or 5 days and see what happens and come back in and see me. Well, now we're 3 weeks into this injury,
at best,
what's the sleep deprivation like? What's the sleep tolerance? What's the work schedule about? Family lives, quality of life, family life impacts everything that goes on for a lot of these people. So all we did was kick the can down the road.
And I'm going to add one more to that typically happens as well. Primary care physician then refers you to an orthopedic surgeon, which then takes 6. I know orthopedic surgeons that are booked out till almost April, and it's December right now.
Right.
And some in May. So if you're waiting that long in that amount of pain, and then you get into the orthopedic surgeon, there's a huge percentage of them that end up coming back to PT.
Exactly.
Some insurances require it. And the majority of cases get better with PT anyway. So you're kicking this can down the road, spending all this money, loss of work, miserable, hard family life, potentially causing some significant damage because you're waiting too long, when you can get into a PT almost today.
Well, and that's just it. That's, like I say, what's the shortest distance between two lines? It's direct. Yeah. So if your Rolodex or contact list has your physical therapist in it, what are you going to do? You're going to call them. And the likeliness that you're going to get in within 24 to 48 hours, I mean, if it's Saturday, you might not get in till Monday. If it's Thursday, it's a high probability you're getting in before Friday at 5 o'clock. If it's a Monday, it's a very high probability you're getting in before Tuesday at noon.
Yeah, and if you're calling PT clinics and they're like, oh, we're 3 weeks booked out, call it everyone.
Yeah.
Call me.
Yeah.
Like, I'll get you into someone within 24 to 48 hours. Like, I know all of my contacts. That is my bold promise as a practice owner. I will do everything in my power, and all of my team knows this, to get you in within 24 to 48 hours.
So, where I worked for 30 plus years, we took walk-in patients. So if a patient walked up to the desk and said, hey, I've got a referral for physical therapy, what do I need to do? We would say, have a seat.
It'll be a few minutes.
They may not get an hour eval. They may get 5 or 10 minutes kind of as a triage model. Like the training on the sidelines of an athletic injury type thing. I had the good fortune for a lot of years to work with Dr. Alan College, who was the medical director of the Utah Labor Commission, who at one point in time graduated PT school, decided to go back to medical school, and treated spine injuries along the Wasatch Front for over 30 years. And, he came up with a model to talk about, as it related to workers' compensation or injured workers, of a triage model. A lot of times you look at the triage model and an evaluation that we don't need to spend an hour on a grade 1 ankle sprain. A 20-year-old student athlete at the college or high school level or whatever, a grade 1 ankle sprain, unless there's some real underlying factors, you kind of have a knowledge and a quick insight as to what you're going to do with them. So do you need to spend an hour with them in an eval versus a 65-year-old total knee patient that's 2 days post-op? The eval is going to be far different because there may be other premorbidities involved and other factors that are going to come into play. So using the triage model in a walk-in care or, the quick 24-hour turnaround allows you to create what with a patient? A sense of urgency. You feel their pain. And why did physical therapists get into the business?
Want to help people.
Bingo. So to help people 3 weeks out is really hard. To help people in 24 hours or at the point of entry on a walk-in situation, that changes your relationship. It changes their aspect and understanding of what you can do and the impact that physical therapy can have instantaneously.
How is physical therapy impacting access to care right now?
I believe it's accessing care in a greater volume in the sense that it's quicker and easier to get into from a big picture standpoint.
Quicker, easier, and even better.
Oh, yeah. Yeah. Well, it goes back to, if you want the best cheesecake in the world, are you going to make it? You're going to buy it? You're going to go somewhere, and test out 12 cheesecakes? No, you're going to go to let's say Cheesecake Factory. Maybe that's the best one.
Oh, they have good cheesecake.
Okay. But it's the same thing. You use the same analogy with medical care. If you want your ankle to get better faster at the most cost-effective and the most time-sensitive point, you're going to go see physical therapy.
Oh, I got a story to tell here, man. I have so many patients, or even people I see in the community, they'll be in a boot and I'll be like, hey, what happened? Oh, I sprained my ankle. My heart usually stops. I'm like, and you're in a boot? Why are you in a boot, right? Like, these are all things going through my head. And obviously they trust whoever gave them that advice. And then I always ask them, like, can I see you in my clinic? Because the clinical practice guidelines state no boot. Like, why are we treating ankle sprains with boots? That is literally one of the worst recommendations on the market.
Right.
Like, we should not be bracing in that way, right? Yes, we need to protect that joint, but there are better ways to do it. You should not be in a boot for 6 weeks. Like, it literally degenerates the tissue. The tissue is not getting blood flow. We want to be moving the ankle, and adding weight to the ankle depending on the level of sprain immediately. There should be things that we're doing day one. Why do professional athletes bounce so quickly back from an ankle sprain or a hamstring strain? It's because they're expediting the process by getting them to the right people first. And I'm not saying that physicians are not doing a good job at managing them, but they're just not trained at that level to be managing them. There's a lot better ways to manage these things and getting to the right person at the right time.
Well, it goes back to the time factor. An average physical therapy appointment's going to be no less than 45 minutes. And in some cases, an hour and 15, hour and 20 minutes. So there's all this opportunity for physical therapy to educate the patient, the common public, and that transpires on to other resources. If you have a good experience at physical therapy and you become educated on your injury or your injury care or your post-operative care, not only during the course of care, but 2, 6, 8, 12 months down the road, what's the likeliness that if your family member, your grandma, whatever gets injured, you're going to say to them, go see my physical therapist? Because he or she helped me better understand the benefits or non-benefits of a boot. Circulation, movement, strengthening, advancement, all those factors, they're not going to come from the primary care physician because they're not seeing you 3 to 5 times or 10 times. They're seeing you once or twice for 5 to 20 minutes.
Yep.
Versus a physical therapist is 30 minutes to an hour.
And there has to be a progression.
Right.
So the physician may be able to give you the initial recommendations if they're trained on the updated research. But there has to be a progression of it. You cannot stay where you currently are. We used to use this term rest. or no, RICE.
RICE.
We'd RICE our injuries: rest, ice, compression, elevation. The physician that coined that term came out, I can't even remember, a decade or so ago, and said I was completely wrong. We should not be resting injuries. Resting is actually one of the most damaging things that you can do for an injury. So there's other terms that have come out. There's a term called police, which is protect, optimally load. So we got to move it. But optimal load is tricky because you got to know the level of injury and how to load it, how to move it. And then you have your ice, compression, and elevation. And even ice, we don't push as much as we used to. Ice we'll use for the first 24 to 48 hours. But then we're realizing it's actually delaying the healing process because you're vasoconstricting, you're limiting blood flow to the tissue when we want to get more blood flow. So the chronic use of ice is actually delaying the healing process. Also, NSAIDs. And there's another term called peace and love. I can't remember the whole acronym. You can Google it, but essentially there's a portion of NSAIDs, so non-steroidal medication. So essentially that's vasoconstricting as well. So it's limiting blood flow to the tissue. So we're actually saying the new recommendations is not to take ibuprofen unless it's for pain. Right? If you're taking it for inflammation, you're icing for inflammation, it's not really doing a lot for your inflammation because it's vasoconstricting. So sure, it's limiting fluid going to it, but it's also limiting fluid coming out of it.
Oh, good point.
So those are two recommendations, a lot of recommendations that have been removed throughout time. And if these physicians are not caught up on the research, it's hard for them to give those recommendations. And that's why the tables are turning.
Right.
They are experts at illness and disease and getting people quality of life on those ends, right? Their job is not to maintain the top level research on rehab. That is now ours.
Exactly. You know, it all comes back to relationship development, access, and time. And physical therapists are some of the best, if not the best, in the working model of musculoskeletal injury care.
Yeah.
You know, whether it be a work-related injury, a sports-related injury, mowing the lawn injury, the weekend warrior, you know, all those factors. The physical therapist is just the great, easy point of access and really provides the greatest value personally to the patient.
Yeah. So I think we've tooted the horn of PTs enough. Do you think?
Nah, I don't know.
Let's jump into why does this matter for a patient that physical therapists get paid well? Why does that even matter?
Well, if the physical therapist is your greatest resource, shouldn't they receive the greatest value?
Yeah.
I mean, maybe that's just my opinion.
And the thing is, if you were to compare salary rates and tuition rates of a PT to a PA
Yes.
or a DNP, which is very similar education,
Yes.
what do the numbers look like?
Oh, it's more than 30% difference.
Why is that?
I think
You
part
have
of
the
it,
best view because you understand all sides. That's why I'm asking you that question.
I think personally, I think the physical therapists have just taken it on the chin for so long. You know, I think that the dentists, the orthopedic surgeons, the general surgeons, the neurosurgeons probably learned a long time ago. They figured out that they've got to start communicating and figuring these things out long before it's too late. You know, we talked about it earlier in this conversation about contracts that have been sitting around for 20, 30 years.
Mm-hmm.
You know, physicians didn't let that happen to them. You know, orthopedic surgeons, they got to kind of together and collaborated together and said, yeah, you know what? We need to be aware of these factors. So I think that the reason the physical therapist got into business was to help people. Now, it doesn't mean PAs and nurse practitioners and orthopods didn't do the same thing, because they did. But, you know, is the sex appeal of the physician versus the physical therapist, you know, kind of the trademark of it, is that where it's at? Physical therapists are kind of this, you know, underlying unspoken hero in so many instances. And they're treated kind of like, you know, the last of the care model, which is too bad. I think that there are efforts out there, not only on the state level, but the national level, to try and change some of that. I just think we're 15, 20 years behind the schedule of where we should have been.
And absolutely. I mean, if you know the history of physical therapists, we started as really ancillary services, right? I mean,
Right.
even before the associate's degree, we were just helping surgeons with the rehab process, not even a degree or certificate. And then it's progressed to an associate's degree, and then a bachelor's degree, and then a master's degree, and now a doctoral. So it's been an evolution.
Right.
So we have been the ancillary service in the basement of surgeons' offices. And that part of our history doesn't go away. But our profession has evolved, and it has become more educated, more informed, increased value to society. And it's just important that the payment models adapt with that evolution as well.
Exactly. If the greatest outcome is coming as a result of the physical therapist and his or her efforts, because again, it comes back to after the surgery's done, where are they going? What's happening? The surgeon isn't doing daily, weekly checkups. They aren't doing daily, weekly strengthening, conditioning, education. It's the physical therapist. So he or she that's providing that resource, that benefit, needs to be compensated and looked at in the same manner as the surgeon, in my opinion. Because if we don't have that piece, what do we have at the end of the day? We've got a surgery that probably went very well, but the outcome of the surgery is going to rely on a musculoskeletal specialist to help him or her advance back to either what they were doing or their future goal of whatever they want to do,
And I think every great surgeon understands that.
Oh, yeah, they
right?
do.
And my hope is that the patients understand that value as well, and that the PT it's part of that healthcare team. Just not like an assistant or an ancillary service, but a necessary part of that process, that you cannot remove it, that it's one of the most valuable parts. Sure, that surgeon is extremely important, but without the coupling factors of the rehab experience and making sure we're hitting those milestones and the complete focused, customized care, that surgery will be a failure. It cannot function well without the musculoskeletal team.
Exactly. I remember as a teenager when I injured my knee, the doctor drained the blood off of it, got the swelling down, did his thing, and he said, okay, now go see your uncle. They had a great relationship. They knew each other. I knew the surgeon, as a child because of injuries. He had done the back surgery on my mother, it goes back to relationships. But at the same time, the minute he got done draining my knee, he said, okay, go see your uncle.
And go to work.
And go to work.
This is where it all starts.
Exactly.
This isn't the end of the journey. This is the beginning.
And so my uncle, the physical therapist, started what? Here you go. And he's got you on conditioning and whatnot. I remember as a teenager, at the time, part of my physical therapy, I don't know if I would recommend that today, was playing 30 minutes of basketball after my physical therapy treatment each day with a bunch of gorillas to see how my knee was stabilized and if it could sustain the pressure. It was a lot of fun, as a teenager. But at the same time, I learned a lot from what I did and how I was treated and what I needed to do. I mean, he taught me, kind of guarding issues and things to be aware of and pay attention to, so that it hopefully wouldn't happen again in the future. So again, you look back at those days and the relationship between the physical therapist and the orthopedic surgeon at the time. I mean, I was in the orthopedic surgeon's office less than 10 minutes. And then, however many visits, probably 7 to 10 visits for my knee care after the fact.
So 10 hours with a PT, but 15 minutes with orthopedic. Like, what does that do for your care? Just think about that. The quality of time that you spend with a certain provider teaching you, because ultimately healthcare is about education.
Right.
The more you know, the more you're educated, the better your quality of life will be.
It's exactly right. I mean, we're going to keep beating this dead bush here, this dead horse, but it's time. And the most time that an injured worker or injured person gets for a musculoskeletal injury is with physical therapist.
Yeah,
at the end of the day. I mean,
tell us why this primary care bill I mean, obviously we've talked about how we're the first in the nation to do this. We're leading from the front. Why does it matter to the PT, and how is it going to get them paid more?
It matters to the physical therapist from the standpoint of recognition, and we've had direct access for a lot of years. Primary care gives a label that the public recognizes. Direct access, the public doesn't understand what that means. But you say primary care, and the public understands what that is. They understand the definition of it in the general sense. So to the physical therapist and to the public, it creates a bond and a new relationship or an enhanced relationship. The value can come from many different facets. We're researching now the opportunity or the idea that physical therapists could utilize E&M codes. Now, for those that don't understand CPT coding, we won't go into the great history of the world of CPT codes. Every medical provider bills based on a CPT code, which is a definition of the care that's provided based on the data service.
And there's an allotted price to that code that they put down on paper.
Exactly.
So they say, this is the code, and now we're going to get paid X amount because of the code that I chose.
Exactly. So physical therapists have a group of codes. Physicians have a group of codes, neurosurgeons, orthopedics, it doesn't matter. You pick your specialty, there's a group of codes to utilize by profession. Subsequently, primary care utilizes a subset of codes of their own, predominantly for the same thing that physical therapists do. Now you take those same codes for a primary care instance or interaction, and in my opinion, physical therapists should be able to start utilizing those same primary care codes. E&M is what the codes are referred to, is evaluation and management. That's what E&M stands for. So if a physical therapist is evaluating a musculoskeletal injury and managing the musculoskeletal injury, why shouldn't we be using the code?
Absolutely.
So it's going to take some time. It's going to be a long education process. Payers need to understand the value of it. One of the challenges we face right now is that payers need to see the value, not just hear it from Ty or Brad or somebody of that nature. They need to see it. And a lot of times, a paper claim that comes through or an electronic file claim that comes through for an injury or medical care doesn't tell a story. A picture tells a story. An information tells a story about what's going on. And those are some of the models we need to start looking at to share, because, if you show somebody the color of orange versus just tell them the color of orange, it has a whole different impact.
Absolutely. For the therapists that are just thinking like, well, we passed the bill, but now we're not getting paid more, what would you say to them?
It's a marathon, not a sprint, number one. Number two, insurance companies have models for reasons, and they have co-pays and deductibles for reasons. There's utilization issues that have to come into play. So at the same time, you have to take into consideration that it's not just this carte blanche, open-ended credit card of services and stuff that can be available based on the fact you've paid a premium or an insurance premium or for a monthly benefit. So it's really boils down to the fact that we need to educate the payer, the insurance company, about the value of musculoskeletal care and where it's coming from. Historically, they've seen physical therapists as utilizers. Why? Well, after a total knee, let's say 15 visits. Mm-hmm. Okay, so what's the bill from a physical therapist? Well, it's not dollars that they're necessarily looking at. It's visits. It's utilization they're looking at. Okay, that 15 visits to the physical therapist is probably not much more than a ER visit on a Saturday night at 2 a.m. So you think about that. I mean, there are ER bills for some instances that are $3,000.
Yeah, you think about it. Like if people didn't go to physical therapy and utilize those steps, where would they be instead? What is
Exactly.
the alternative? So these payment models are looking at, oh, okay, you're using 12 visits with a PT. That is cost. If you didn't use those 12 visits, where would you be? You'd be in the hospital. You would be in the hospital multiple times. You would be having all kinds of other issues years and years down the road. So it's actually a big prevention piece if we utilize it.
But the models are built that if I go to the ER, my copay is, let's say, for instance, $100, and I go one time. If I go to physical therapy and I have a copay of $50 each time, and I need to go 10 times, the patient's paying what? $500.
Yeah.
So part of it is a mindset. Part of it is a thought process of cost. If a patient can't afford to go 10 times, but they can afford to go once, what are they going to do? So there's a lot of problems with the system. There's also a lot of benefits to the system.
What are you hoping that changes within the next couple of years?
I hope that we can change the deductible and copay vision between the payer and the patient, and the relationship and the understanding of it. I hope that we can help patients understand the value of physical therapy and the resource, and having that direct contact, in their Rolodex or in their contacts on their phone. Because 1 or 2 visits a year to a physical therapist of prevention or maintenance or tune-up, if you will, is probably worth 5 years of ER bills.
An ounce of energy is worth a pound of cure. Right?
Exactly.
I mean, if we get to Medicine 3.0, I believe we're getting there. It's focusing on prevention.
Right.
If we get to the point where people go and do an annual checkup with their physical therapist for musculoskeletal prevention, how much injury could we actually prevent? Right.
Well, and you're a part of these models that are out there in this team approach that are far different than they were 10 years ago. Mm-hmm. Physicians, physical therapists, nurses, anesthesiologists, chiropractors, all these people are coming together on a regular basis and talking about how and what and benefit and where the greatest resources are and community and all those things. 10 years ago, we didn't really have that a great deal.
Yeah.
And now it's not uncommon for, these groups to get together from 1 to 3 to 5 times a month, scattered throughout different regions or different communities, and talk about the resources that are available out there. Now, how do we convey that to the public? How do we make the public aware of, hey, I've got a musculoskeletal injury, I need to go see Brad?
Yeah, absolutely. Tell us what your advice would be to the physical therapists of how to claim their role as a primary care provider.
My advice would be don't overthink it.
We got a lot of overthinkers.
Yeah. Direct access. If you think about direct access, why is direct access, the term, different than primary care?
It's not. There's nothing really different.
Right. If I'm injured and I go see my primary care physician, or I go see my physical therapist, and the primary care physician finds something that either needs lab work, imaging, maybe a specialist, or if I go to my physical therapist and he or she says, hey, you know what, I'm concerned about this, and they refer me on to a specialist or for imaging, how is that different? So the term primary care, in my mind, is a much better community or public perception term than direct access. Direct access has been around for 30, 40 years. Physical therapists have been using it for a long, long time. The John Q. public that's educated has been using it for a long time. We need to recoin the phrase direct access to primary care. Then John Q. public goes, I understand primary care. I understand the value of my physical therapist and my musculoskeletal injury.
Yeah, and if there's anything I could add to that is just a second what you're saying. Direct access to primary care, it's really the same thing. You're seeing patients at their entry point, right? You were already managing it as a primary care role, and now you just have the title that people can recognize you as something you've already done. So it's not you're not taking on any additional liability. There's no change in scope of practice. You're doing the exact same things that you have done before. And now you just get the credit, right? You get the statement that says you are at this highest level. And society knows that term very well. And they'll be able to see us as we truly are. Because this evolution has taught us that we were ancillary services, that we were a small portion of it. And as we've evolved, now it's just matching the evolution, that we are doctor of physical therapists or doctor of physical therapy individuals, right? Like we have doctorates. And now the primary care role is matching that as musculoskeletal experts, because that's what we studied so in depth for, is to understand that system extremely well, to know how to treat those injuries at the highest level.
Well, and the term primary care also refers back to, I don't know all the statistics off the top of my head, but primary care physicians aren't as affluent as they were 40, 50 years ago. Recently I put together a graph that talks about and shows the primary care physician, the ER model, the urgent care model of what's transpired since the 1970s. So we've got a 50-year picture of what's gone on. If you got injured or had an episode of care that was required in the early 70s, you basically had two choices: primary care physician and the emergency room. Urgent care has evolved in the late 70s into the 80s and really became more popular in the 90s. So primary care physician utilization for injury care, initial injury care, has dropped by more than 30%. Plus the fact that primary care physicians, there's not as many of them. There's a shortage of it. We happen to live in the state of Utah, currently second to last in the nation in number of primary care physicians to the number of to the population of the state per capita. So that's a big factor. So educating the public on primary care, musculoskeletal care, does what for that? We talked about at the beginning. How long does it take to get into the primary care physician's office? Well, so the model I built that shows the 50 years of access and what's been going on, urgent care is obviously spiked. Direct access also grew in the last 30 years as a result of that very thing. So primary care physician access or utilization has dropped dramatically. A, lack of or shortage of physicians. B, utilization of urgent care and or ER. And C, direct access for physical therapy.
I love it. What last advice would you have? Number one, for our patients in understanding all of this. And number two, for the physical therapy profession.
Advice for a patient. That's a good one. Advice for a patient is to understand your healthcare service, your healthcare benefit. Study it, look at it, understand what it does for you and how it can work and serve you best. Part of that. Secondary to that, I think that understanding your ability to drive your own care, to be your own kind of in the driver's seat of what needs to happen for you. A lot of times people get stuck in this rut of, I've always gone to my primary care doctor, that's what I'm going to do. So they just keep going to that same path. Why? If you need gas, you go to the gas station. If you need milk, you can go to the grocery store. If I've got an injured low back, go to a physical therapist. Don't go to the ER. Don't go to, unless it's 2 a.m. and it's a problem, I guess. But secondary to that, I think for the physical therapist, I think it's don't overthink it. Don't think that it's this whole new nuance beyond what you've already done and what you are already doing and have been doing since you started practice. Direct access has been there for a long time. We're not changing it. We're not relabeling it, other than the fact that we're giving the John Q public the voice and the understanding that you're primary care.
Yeah, I love that. Ty, thank you for joining us today on the podcast, and thank you for starting me on this journey. I don't think I've ever told you personally, but so much gratitude in my heart. I never thought I'd be in advocacy or legislative work or even on the board of directors. It's a lot of work and it's extra things added to my plate, but it's added so much value to my life and given me relationships that I can call you at late at night when I'm in Texas on the side of a road to ask you questions. It's given me resources that have helped all of my team. It's given me a voice for my practice and allowed me to educate the rest of my profession and other providers on the true value of what we do. And I'm so grateful for that $2 bill that came in the mail many years ago. And I'm grateful that I get to hold that bill today and remember the value that we create as a profession, because we literally are changing so many lives. So thank you for what you do for advocacy. Thank you what you do for the hundreds of miles that you travel in your van every day. And you've put so many miles and you've advocated for my profession for decades. And I'm so grateful for it. So thank you.
Well, you're very welcome. Thanks for having me. And, I hope that the public and the physical therapists will continue to look at their own advocacy and their own understanding and the resource that physical therapy can be.
Absolutely. Thank you.
You're welcome.